This afternoon, we're going to be talking about acute flaccid myelitis and anticipating the next outbreak. Next slide. So I have no disclosures. And the learning objectives for today's talk, after we finish talking about AFM, you should be able to explain the latest theory behind the biennial pattern of AFM outbreaks, recognize the signs and symptoms of AFM, and additionally, have confidence in screening for AFM in your clinic or in the emergency department. So AFM is an exceedingly rare polio-like illness affecting primarily children. And on this slide, you can see some of the classic MRI findings associated with AFM with the predominant gray matter involvement seen here. Next slide. So we're going to start with a typical AFM presentation here. A 6-year-old boy was brought into your clinic by his parents. He's had URI symptoms for about a week, which had been getting better. But then he developed neck pain and weakness of primarily the left arm. He was initially seen at urgent care a couple days ago, who recommended watchful waiting. And over the last couple days, his symptoms have progressed in a profound way with asymmetric quadriparesis, neck and truncal weakness, and a soft voice. You sent him to the ICU and he is intubated for acute respiratory failure the following day. So AFM affects primarily young children with a median age of approximately 6.3 years. Non-polio enteroviruses are thought to be the cause of AFM. Indeed, there is the most evidence linking enterovirus D68 in particular to AFM outbreaks in the United States. The case for D68 is rather compelling. There are robust temporal and geographic correlations between AFM cases and D68 circulation. The pathogen most often found in biological specimens collected from patients meeting criteria for AFM is indeed D68. Mouse models infected with D68 develop limb paralysis, and cell models have confirmed the ability of D68 to infect and damage neurons directly. So there have been over 600 cases in the US since the CDC began tracking. The first case series describing a number of children in California with AFM was published in 2012, after which national reporting started. Outbreaks of AFM have been occurring in this rather curious biennial pattern since. So you can see spikes in 2014, 2016, and 2018 as illustrated here. It is thought that increasing population susceptibility, mostly children, to the enterovirus D68 underlies the timing of AFM outbreaks. Essentially, most infections are mild or asymptomatic. Less than 1% of infections result in AFM. And these widespread outbreaks serve to generate herd immunity. And then it takes about 2 years for enough babies to be born at the current birth rate for the population susceptibility to reach a critical level to allow for an outbreak to occur. Park et al. Used surveillance data to create a mathematical model to attempt to predict AFM outbreaks, and the team predicted a 2020 outbreak based on the available data. And indeed, there was a lot of fear and speculation about a potential AFM outbreak in the fall of 2020. But there were only 31 cases reported to the CDC in 2020, which is rather interesting. It's hypothesized that mask wearing and social distancing reduced the transmission of enterovirus D68 during the past year and prevented an outbreak from taking place. Of note, the susceptible population is likely higher than ever. And once COVID-19 restrictions are lifted, it's theorized that we'll see quite a large spike in cases, perhaps larger than ever. So it is essential that we remain vigilant. 80% of patients ultimately diagnosed with AFM are initially misdiagnosed by providers. And a significant number are sent home after being seen by their first provider. This prompt diagnosis is essential because misdiagnosis is associated with higher rates of ICU admission, increased need for ventilatory support, and delayed treatment by 1 to 2 days. So how can we, as general pediatricians, decrease the rate of misdiagnosis, and find that needle in a haystack. Data from the most recent meta-analysis published by the AFM Working Group provides insight into the patterns of clinical presentations of kids with AFM. And it's really important to be familiar with the typical presentation so that you can readily identify it in the clinic or the ED. A preceding viral syndrome is almost universal. It's most often respiratory, but it can be a fever alone, gastroenteritis, in some cases, hand, foot, mouth disease. The subsequent onset of neurologic symptoms occurs 1 to 10 days after the viral prodrome. In 100% of cases, the neurologic symptoms progress over hours to days. The weakness is often accompanied by meningism, and pain in the limb, paresthesias, often heralds the weakness. Patients typically develop asymmetric weakness, most often of the upper extremities, but can certainly impact the lower extremities as well. Weakness is often associated with hyperreflexia and areflexia, and 30% of patients demonstrate cranial nerve deficits as well. Sometimes only one limb is affected, sometimes all four, and there's a really broad range of severity of symptoms, from barely discernible weakness to flaccid paralysis, requiring respiratory support in up to 30% of cases. Bladder and bowel dysfunction are really common, and then importantly, sensory deficits other than neuropathic pain or paresthesias are very uncommon. Should make you think of something else. Next slide, please. So knowing the illness strip can help you not to miss AFM in the clinic. So if a parent comes in with their boy or girl, and they tell you a history of several days to a week of viral URI symptoms, the kid was initially getting better, but now the parents tell you that they haven't been using their arm, they may be having difficulty walking, or they're lethargic, not acting themselves. It's important that you think about the possibility of AFM. So to perform a quick screen for weakness in the clinic, you can ask the child to raise their arms or their legs, so you at least know their anti-gravity in all their limbs. The weakness is often proximal, so you can have them get on the floor and have them get up. You can have them jump in the clinic. It's important to listen to them speak and ask a targeted history with questions about swallowing difficulties, which may be evidence of bulbar dysfunction. And then watch them smile or cry for evidence of facial weakness. It's important to get them up and walking, and check the reflexes with that reflex hammer. I know that you all carry around with you in clinic. Next slide. All right. So here are some take-home points from today's talk. We may see an AFM outbreak in 2021, depending on the relaxation of COVID-19 restrictions. Kids won't tell you they're weak, they just stop moving. Acute weakness is always a neurologic emergency. It may not be AFM, but it's still something that warrants evaluation in an emergency department. And then to perform a simplified neurologic exam, have kids raise their arms and legs at least, and make sure to check reflexes. If you detect any abnormalities on your exam, refer to the emergency department. Here are my references, and really appreciate you tuning in this morning, and I hope you have a good day. If you have any questions, you can pop them in the chat and I'll try to answer them as soon as possible.
Great, thank you so much, Glenn, on such a wonderful Grand Rounds warm-up on acute flaccid myelitis, which we may be seeing more of in the coming year. So thank you so much. So now I'm going to turn it over to Debbie Prasad, who is the interim director division director of infectious disease, who will be introducing our main Grand Rounds speaker today.
Great. Good morning, everyone, or good afternoon. And thank you, Jeanette, for giving me this opportunity to introduce Dr. Allison Agwu. So it really gives me great pleasure to introduce Allison. So Allison Agwu is professor of pediatrics and internal medicine here at Johns Hopkins University School of Medicine. She received her fellowship training here, both in adult and pediatric infectious diseases, after completing a combined pediatric internal medicine residency training at University Hospital in University of Cleveland in Ohio. So following her fellowship training, Dr. Agwu also received a Master's of Science from the Johns Hopkins Bloomberg School of Public Health. She's renowned for her work and clinical research interest in HIV/AIDS, specifically in youth and young adults, with a goal of really optimizing outcomes for youth and young adults living with HIV through an in-depth understanding of health disparities and health delivery systems and the treatment strategies to be able to optimally manage and treat HIV infection in this vulnerable population in order to achieve the near normal life expectancy that's being seen in adults living with HIV. Dr. Agwu is the founder and medical director of the ACE Clinic, which is the Access and Care Early Clinic here at Hopkins. That's integral to transitioning care of youth living with HIV from pediatric to adult care settings. She's also the program director for the Pediatric Adolescent HIV/AIDS program and the principal investigator of our clinical trials unit, serving both the International Maternal Pediatric Adolescent AIDS Clinical Trials Network and the Adolescent Trials Network. Alison is renowned nationally and internationally, where she serves on the U.S. Department of Health and Human Services Adolescent and Adult Antiretroviral Treatment Guidelines Committee and on the board of directors of the HIV Medical Association. I'm proud to have served as Alison's mentor for the past 18 years and to watch her develop into a leading HIV researcher focused on youth and young adults living with HIV. So her talk today is optimizing outcomes for youth living with HIV, breaking silos and changing paradigms. Take it away, Alison.
Thank you, Debbie, for the kind introduction. It really is my pleasure to be here, to be home, to talk to you about something that I'm very passionate about. So these are my disclosures and my objectives, which are always manifold. First, to really explain to you the unique aspects of caring for youth with HIV, review the advances and innovations in HIV treatment and management strategies for youth, but to spend a lot of time discussing opportunities for clinical care, research, and not unimportant advocacy to optimize the outcomes for youth with HIV. Central to a lot of the talk today will be the idea of silos. And silos can be mental or physical or logistical silos or groupings or departments that serve in a way to separate communication and cooperation. And this talk is a lot about reducing the silos in my mind, but also natural physical and logistical silos as it relates to youth with HIV. I stand before you, we're at a training institution, and I really want to make sure that you understand while I sit here and talk about all these things, and I believe that I could, and so I did them, but it's not without my super PAC of people that have been here supporting me, mentoring me over the past 18 plus years, including Dr. Prasad, who introduced me, and then Dr. Kim and Dr. Bartlett, who were respectively the PEDS and adult ID chairs when I came here and were instrumental in bringing me here, and who we lost this year. So first, taking 30 plus years back and thinking about where we came from, the beginning of HIV to the advances that have led to improved outcomes overall. And that was a result of diagnostic tools, opportunistic infection prophylaxis and treatment, immunizations to decrease the risk of opportunistic infections, but critically antiretroviral therapy. And here, and as David Ho was Time Magazine's Man of the Year for his discovery of highly active antiretroviral therapy, which is not just one, not two, but 3 agents against the virus and components of the virus to then lead to viral suppression or an undetectable viral load, which is the goal, which then allows immune recovery and then the decreased risk of transmission. Additionally, antiretroviral therapy can be used for pre-exposure prophylaxis as well as post-exposure prophylaxis to prevent the need for development of HIV infection. It's important to think about HIV in a continuum of care. And we talk about the diagnosis, but there's a diagnosis, then there's a health provider, they're starting HIV treatment, and there's a whole cycle or journey that goes on to get to that goal of having an undetectable viral load. When I first started HIV treatment, now thinking back to the early 2000s, it was handfuls of medicines and on a daily basis given 2 and often 3 times a day to suppress virus. Now when I prescribe regimens to patients, it's usually 1 pill and once a day. And this chart really shows the remarkable development of agents that have happened over the past 30 years to get to where I can give that person 1 pill with multiple options available, with our first injectable option approved by the FDA earlier this year. The mantra has been simplified treatment, fewer pills, smaller pills, fewer drugs or drug classes, fewer drug-drug interactions, fewer side effects and fewer toxicities, and fewer dietary requirements, no need for a large meal to take your medicines. And so there's now a battle going on in terms of less may actually be equal and then a lot of times better for both treatment naive as well as treatment experienced individuals. Debbie alluded to in our introduction the survival, the near normal survival that we see with individuals who have HIV, who are on treatment. And what you see in this graphic displayed very well is in the early years of HIV, where related life patient survival was maybe 8 years. And now this, for an individual who's 20 years of age, you can say survival could be as long as 55 years beyond their initial diagnosis with taking antiretroviral therapy. This slide is what keeps me up at night when I think about most people that I take care of. When you look at the persons who are age 20 who are not taking their medicines, and their life expectancy will not or does not reach those who are taking medicines, and definitely does not reach that of persons without HIV. So let's talk about those young individuals. So about 1 in 5 individuals who are diagnosed with HIV, about 40,000 people annually, every year, about 1 in 5 of those are between the ages of 13 to 24. HIV is a story of disparities. When we think about 12 to 15% of the population being African-American, when you look at those who are diagnosed with HIV, significant proportions outpacing their portion of the population are African-American or Latino. Now, when you drill down on those who are living with HIV in ages 13 to 24, left side of the slide is males and the other side is female. Predominantly young men who have sex with male make up a significant proportion of those who are living with HIV. And for females, about 50% of those with heterosexual contact. This is an area that I spend a lot of time thinking about, is that perinatally acquired individuals who are now aging into adolescence and young adulthood, making up about 10% of males living with HIV ages 13 to 24, and about 40% of females. And this is not decreased likelihood of males to survive into adulthood. This is just outpaced by the number of males who are acquiring HIV through MSM activities. I'm Hasia Yusuf, one of my postdocs, and you'll see throughout the presentation a halo around the faces of my postdocs and their names highlighted in yellow, just to really underscore the trainees and the generation that I'm hoping to bring behind me that highlight a lot of what we're seeing for young people with HIV. So the medical challenges, there's feeling normal, there's advanced disease, even when you feel normal, comorbidities, significant amount of mental health, anxiety, depression, PTSD, neurocognitive delay and dysfunction, particularly among the perinatally acquired, as well as delayed puberty and short stature. And then treatment issues in terms of just being highly treatment experienced. I told you that we're down to 1 pill for treatment, but for many, 1 pill is too many and it's too complicated. And how do we get to no pills? And then there's treatment fatigue. Additionally, for individuals who have been born with HIV and aging into adolescence and young adulthood, they may be drug resistant, but even individuals who are newly diagnosed may have drug resistance. And so thinking about those issues as things that complicate the medical issues. But then psychosocially, though we have come a long way, we are still dealing with significant amount of HIV stigma. And many of our young people are also dealing with multi-level stigma, internal as well as externalized stigma for their diagnosis, as well as their sexuality or other factors, disclosure, limited support systems, there's poor adjustment to illness, limited health literacy, lots and lots and lots of logistical barriers, insurance, they may have kids of their own, transportation, housing, poverty, unemployment, and underemployment, and then there's the attempt to be normal, desire to be normal. It really is critical when we're thinking about psychosocial challenges to not forget about the issue of intersectionality. I talked about the racial ethnic disparities that we see with HIV. There's the gender identity and also sexual identity issues. This intersectionality that we see with HIV complicates the psychosocial issues that we deal with in young people. So I always focus people to the continuum of care for youth with HIV. This is a concept that was first publicized by Ed Gardner in the mid 2010s, talking about the step down from those who are diagnosed with HIV to those who are engaged in care, prescribed ERT, and then suppressed viral load. And initially in the turquoisey color, the adult cascade came out. And there was an uproar about the adult cascade, which so few people, only 30% of individuals living with HIV were suppressed, meaning they were on their medications and their viral load was undetectable. Not as much of a splash came out when the dark green data came out from Ken Mayer and others in Boston who did a meta-analysis and showing only about 6% of youth living with HIV were suppressed. And then getting to suppression is one thing, but then staying suppressed is a whole other. When you look at systematic reviews done on why adolescents have a challenge adhering, it's everything from they just forgot to the travel, stigma, they fell asleep, how long they had to go to get to clinic, running out of pills. So it's a multitude of things that may lead to non-adherence. And in the same adolescent, it may be multiple things and at different times, different places. Currently, this is a survival guide for youth with HIV. Find out your diagnosis, so get tested, no matter how uncomfortable it is for you to walk into certain spaces and get tested. Get your diagnosis and deal with it. Take your pills every day, single day, for forever. Suppress your virus, don't infect anyone. See your provider every 1 to 6 months, even though you didn't actually see your provider for many years before. And then get your blood drawn multiple times and make sure insurance is active, do all the other life stuff and contribute to society and live long and prosper. So what are we missing about youth? Life is dynamic, adherence is hard and multifactorial, there are side effects, there's long-term toxicity, there are limited choices. Even one pill may be too much and one size does not fit all, and forever is a really long time. Fatigue, disclosure, stigma, mental health, and quotes, I feel fine, why do I have to do this? And I don't want to be here, no matter how nice you are, Dr. A. So I tell you all this as if as if 18 years hasn't passed. When I was first a Med-Peds fellow and thinking about this, I was told a couple of things. One, it's not a big deal, 18 and above, we don't have that many issues with those young people, they do fine. The adult clinic said, we don't have that many young people in our clinic, but my vibe was something was not right as I sat in the different spaces and felt like the attitudes and the practices may have been different. So when it doesn't feel right, go left. And so let's talk about the first silo, which is research. And it is my own silo, I'm gonna own up. I was lucky to receive both a KL2 and a K23, a Career Development Award, and was supported by a GHU Clinician Scientist Award to be able to get my GTPCI, my Master's in Science, the GTPCI program, as well as to start to answer and ask and answer some critical questions. So this is an African proverb, and it's a Sankofa verb. Sometimes going back is the way to move forward. And I had the opportunity to look back at my old long career goals, et cetera, as I thought about my next steps for this talk, as well as for a K24 application board. And these were my long-term goals in my K23, was one, to develop a transdisciplinary clinical research program to improve the care of HIV-infected youth. And you could tell that terminology is old. We don't say that anymore, we say youth with HIV. 2, to research practical and developmentally appropriate mechanisms and treatment strategies for introducing and maintaining timely and effective ERT to infected youth. 3, to contribute original research to the field of HIV infection in youth and to obtain R01 level funding to support my continued work. That was it. This was my framework, because every K23 needs a framework. And I had several aspects related to the provider and then related to the treatment eligible youth. Treatment eligible because at that time, your CD4 count had to decline to less than 350 before you initiated antiretroviral therapy. And so I wanted to look at knowledge, attitudes of the providers, their beliefs, with the idea that those things would impact their intention to prescribe ART and then ultimately to start ART. And for the treatment eligible youth, the same thing, knowledge, attitudes, psychosocial beliefs, etc., would then impact the readiness to accept ART, whether or not they initiate ART, and to look at success on ART or treatment failure. These clinical observations that I was telling you that I was feeling, I turned into research questions. And what I'll chronicle on this slide is what I found as a result of my K23 investigations. So 1, youth did present with advanced HIV. We saw that in the studies from the HIV Research Network, which is a national network of clinical sites, we found that about 40% of youth were already coming into treatment or into care with a CD4 less than 350, so treatment eligible. And about 20% of those individuals are coming in with a CD4 less than 200. So advanced HIV, or what we'd say is AIDS defined. When we looked at patterns of initiation, youth were less likely to initiate ART, even when they met treatment criteria. Their CD4 recovery was not better, which is a myth. They have these large thymus, and therefore, when we started, even if we waited longer, their CD4 would recover better, and they did not. Providers were reluctant to start ART. And I should say this was work done by Lana Lee, who was a Med-Peds adolescent fellow who was interested in HIV. And she did interviews with providers with peds and adults to ask about their intentions, their knowledge, their attitudes, and was able to publish on that reluctance from the provider standpoint. Youth did have worse outcomes: poor virologic suppression, higher antiretroviral treatment discontinuation, higher hospitalizations, higher care utilization, and poor retention and care. Also, confirming what I was feeling, that urge, that sense that youth do better in pediatric and adolescent settings versus adult settings. And there were differences in how providers of the varied training interacted with those youth. I then went on to decipher treatment, deciphering treatment by asking research questions. So found that suboptimal ART was continued for prolonged periods of time. And this was in PACT 381, one of the first observational cohorts of youth initiating ART in a clinical trial settings, but just observational and collecting data, et cetera, lab specimens. And I was able to do this work in Debbie Prasad's lab and showing that youth were continuing for long periods of time, and there were viral fitness consequences for them developing resistance mutations, though they were continued because providers were reluctant to change. There were treatment options that were limited for youth. One pill was better than multi-pill regimens. This is work done by David Griffith. However, there was still a lot of non-adherence, even with those one pill regimens. There was significant ART resistance at baseline, but also subsequent development of antiretroviral treatment resistance. And a significant proportion of youth had X4 virus, meaning one whole class of antiretroviral treatment was not eligible for them or available to them because of this change in the receptor. And in my first international HIV treatment trial funded by Impact, I looked at the use of 3TC and antiretroviral therapy strategy, monotherapy, versus continuing adolescents on failing ART, which is a strategy that was being done domestically as well as internationally, and looking at whether or not there were benefits to that strategy. And this is the money slide. And what I found here was that in the US, South Africa, and all the sites that contributed, that what we found was continuing antiretroviral treatment was actually superior to switching to 3TC monotherapy. So individuals who switched to 3TC monotherapy were more likely to have a decline in their CD4 count. And as a result, 3TC monotherapy was taken out of the guidelines for the US treatment for adolescents and children, and internationally pushed the envelope to have better access to better drugs for youth and children. So when I look at the body of work in terms of the factors associated with poor outcomes for YHIV, this slide just shows the things that we found associated with ART discontinuation, including older youth, more likely to discontinue, adult clinic, factors associated with loss to follow-up, factors associated with viremia, and factors associated with death. But the thing that kept bothering me was this adult clinic associated with ART discontinuation, loss to follow-up, viremia. When I looked in the HIVR research network, the large majority of youth, 80%, non-perinatal, and 50% of all youth were followed at adult sites. So the answer could not be just send them to pediatric sites. Given that there are more youth seen at those adult sites, fewer patients to each provider, so less experience. And who was caring for those youth regionally varied in terms of what kind of provider training was in place for patients being taken care of by different providers. And so the second silo, again, the mental silo, right? Clinical care. So I was fortunate enough as a fellow to ask for and be offered additional time to spend training under the great Nancy Hutton, who I see is on the call here, who was the founder of the Intensive Primary Care Clinic that was renamed the Pediatric Adolescent HIV/AIDS Program, and Lana Lee took over the program. And with Nancy's vision, the team and clinic, multidisciplinary, the population served primarily African-American and marginalized populations from Baltimore and the surrounding areas, 100% Ryan White funded, which I'll cover in the next slide, youth-friendly, multidisciplinary staff, all really focused on youth, and many of them are pictured here, including past and present staff. The idea is a comprehensive HIV program with co-located services, one-stop shop to take care of children, adolescents, and young adults with HIV. The idea of the clinic that I have extended, being in those Phil's shoes, or tried to fill Nancy's shoes and took forward, is to adapt, respond, and predict. And this is evidenced by a paper that our team put together addressing health inequities exacerbated by COVID-19 among youth with HIV. We saw a problem, we adapted our program to respond to that problem, and then said, here's how others need to do it. So really tried to push the envelope to have others also better take care of young people with HIV. This then parlayed into a bigger HIV MA paper about how to then adapt to use some of the strategies adapted for COVID-19 to improve overall health for individuals living with HIV. Quality improvement initiatives are a must. So part of the YHIV funding, but as well as Part D funding and what the clinic does in terms of how do we best take care of our patients, whether it's to improve adherence, our own antiretroviral stewardship, are we given the right drugs for the right time? Do we need to change what we're doing and how do we do it better, and not being afraid to look at what we're doing and to call ourselves out to do it better? And then integrating mental health, we sort of integrated mental health into the program to try to, again, improve how young people engage in mental health. And then community engagement is a critical part of it with the parents, families, and communities, and the youth specifically. I highlight our Youth Adverse Advisory Board, fearlessly led by Iris Foley, pictured with the youth, but also our interactions with other clinics and programs, and that's our team at the Chase Braxton Walk. I want to highlight Renata Arrington Sanders, Associate Professor in MedPeds Adolescent ID and HIV, who really is the forefront of our community initiatives. And with her team, really has done very creative, youth-friendly, diverse things that actually bring youth to the table. But I would be remiss if I did not spend some time talking about Nancy Campbell, my right-hand woman, who has been the program manager for many years and who will be leaving us in June. A huge loss, but just really want to acknowledge what she's brought to the program. So clinical lessons funding, and I talked about the silo of being research. I said my own silo, because as I was thinking about youth and asking all these questions, I had no knowledge and true understanding of the clinical piece in terms of
Sorry, everyone. It looks like we may have that Dr. Agwu may have had some issues with her internet. We're going to contact her. Hold on 1 second, please.
Am I back?
You are back, and
okay, thank you.
You should be able to share your slides.
Okay, sorry about that. Let's go back. The beauty of Zoom. All right. Are you seeing my slides? Are you seeing my slides?
Yep,
thumbs up.
your slides. It looks great.
Beautiful. All right. So awesome. So I'm not sure what you missed, but I was saying that the clinical lessons in terms of funding. So YHIV, comprehensive care for patients living with HIV, multiple parts, Part A, medical and support services, Part B, Part C, literally different services and different categories of funding to support individuals with HIV. I just highlighted my program manager for Part A and Part B, Nancy Campbell, who has really expanded the kind of funding we've had to support our program. And then Marina Terraforte, my Part D program manager, which is a program that not just funds programs regional at Hopkins, but regionally as well. An opportunity to have advocacy for youth specifically, but also the populations of women, infant, children, and youth. Lots of advocacy related to that as well. All right, but I want to focus back again on that adult clinic versus pediatric clinic. One of the things that I spend a lot of time thinking about is what the differences may be. And if I was in the room with you, I'd ask people to raise their hand in terms of which one of these pictures represents an adult space versus a pediatric space. And it's very obvious to us. There are differences in clinical space, which may not just be the physical vibe, but the actual mental and energy of the space. Disclosure, clinic size, and provider-patient ratio, schedules and flexibility, but different care models, and then provider and staff training and relationships. And again, a potential place for silos. the adult clinic, not talking to the peds clinic, et cetera. And again, alluding to that the need to break those silos and combine those silos. So wearing my adult hat, you can say, am I and other adult providers seeing for our youth that come across? And it's variable transition, different ages and rates of success, variability in readiness to go from the pediatric to adult side, youth poorly engaged in pediatric care, being poorly carried in care on the adult side, parental involvement helpful, but not always encouraged or done on the adult side. Youth have amazing resiliency that we need to tap into. There's lots of depression, hopelessness, and sort of this developing amongst our aging young people. I've survived, and yes, my viral load is undetectable, so now what? And trying to make sure that we prophylax against that. And then limited capacity to maintain the prior level of support and engagement. Continued connection with the ped side is essential. And interventions that increase awareness of the unique needs of youth for adult providers is critical. Flexibility, and where do we go next in terms of the peds providers caring for older patients is really important to talk about in terms of how do we best take care of them. So in 2012, I was fortunate enough to have the support of the Bartlett Clinic in terms of starting a program embedded within the adult program called the ACE program. And this program specifically targeted youth 18 to 30 who are either newly diagnosed or transitioning from pediatric adolescent care to adult care, individuals who had failed in the adult program, or individuals where there was some identified barrier, substance use, housing, etc. Multidisciplinary integrated team is the mantra. ACE nurses, and many of them are on the slide here, social worker, mental health, and pharmacists all together thinking about young people. We have a youth, young adult advocate, and I've highlighted the two that we've had, Tavon Vinson and now Erin Powell, who have been tremendous in terms of engaging those youth, using technology to facilitate communications, flexible clinic schedules, and then having a weekly multidisciplinary team and a bridging the divide team to bring both the adult and the peds clinics together on a regular basis. We looked at what we see for outcomes, and David Griffith, when he was a fellow here, now he's wears this big heavy title of director of Bartlett programs in the community, did a retrospective single center cohort study looking at the impact of the ACE program in youth who are either in the ACE program or in the general adult clinic. And what he saw was that our ACE eligibility criteria worked. There were higher risk youth in the ACE program. They had more substance use, they had more mental health issues, they had more challenges, but they had higher retention and care and lower loss to follow-up compared with standard of care youth here. And this included youth who are transitioning from pediatric care. They're more likely to stay and engage in care compared to those who are in the general adult. Retention and care was specifically associated with more frequent social work visits, more nurse phone calls, more peer navigation, not just peer navigation interactions, but two-way. So sending the message out was not enough, but getting a message back, and that dialogue was critical in engaging youth. Unfortunately, what we did not see was that they had superior viral suppression in the ACE team. And reminding you that overall, we're seeing about 6% viral suppression nationally. Our viral suppression rates are more than that, but they were still not what we wanted them to see. And what that highlighted to us was additional interventions are needed to address adherence to ART among this high-risk population. An opportunity for advocacy. So both about transition as well as how to transition and how to engage youth. I've been able to partner with my young people. This is them testifying at the NIH to talk about navigating pediatric to adult care, using their experiences in the ACE program and advocating for others to support clinical care as well as research into improving transition for youth. And then putting things into the guidelines about how we need to do best practices for transitioning youth with HIV from pediatric to adult care. And this is a section from the upcoming adult and adolescent guidelines that are to be released this year. But really critical is the clinical research collaboration. He's again talked about the silo of being in research and thinking about this differently. But in fact, the clinical spaces enhanced by research, but also go hand in hand in improving trust, in improving access, and really thinking about the clinic as an extension of the research team and vice versa, really working together from a social justice lens. Why not a kid in Baltimore? Why shouldn't a kid in Baltimore be in this study on this drug? And in terms of studies, I was lucky enough, and at the time I got the opportunity, I wasn't sure. But now I thank my George Cyberry for having me as a successor. as the PI of the Hopkins program of the International Maternal Pediatric AIDS Clinical Trial Group, because that actually exposed me to clinical trials in HIV treatment, prevention, cure, comorbidities, and vaccines, which I continue to today, as well as non-HIV studies, now COVID, remdesivir plasma, the populations, their infants, in collaboration with Chris Golden and his team at the Newborn Nursery, bringing prevention of mother-to-child transmission studies to Hopkins, children, adolescents, and young adults living with HIV, and then pregnant women, working closely with the OB-GYN group, Jean Anderson, and now Ahize EK. And sponsors building from impact and ATN to now investigating, not just investigator-initiated trials, but also industry trials. I would be remiss if I did not highlight my amazing team led by my nurse manager, Tweet Anderson, Alicia Collinson-Strang, and Bonnie Anderson. Fearless, tireless, that have really been the key to making sure that research happens and happens well. Here at Hopkins, the first child under age 18 in the world to receive an injectable antiretroviral treatment is Hopkins. The first child in the world to receive islatravir, a new NRTI, is here at Hopkins. And we are top ranked among all impact sites in recruiting kids to pregnant women to the remdesivir trial, which will be able to tell us about pharmacokinetics of remdesivir for COVID-19 treatment for pregnant. Advocacy, really critical to constantly advocate for studies and trials to address this population and to not say no, whether it's the industry or to impact and to be pushing. But the clinical pieces have also informed my own investigator initiative. And here I'd like to pivot quickly and talk about an R1 that I share with my friend and colleague, Maria Trent, called Tech to Check, and technology-based community health nursing to improve ART adherence and virologic suppression in youth with HIV. I told you we needed more. ACE wasn't enough, some of the things that we're doing. And so this R1 is specifically looking at how an intervention called Tech to Check in a randomized format for youth living with HIV who viral loads are detectable, how randomizing them to this intervention, which I'll tell you about shortly, may increase their likelihood of having undetectable viral load. And then to look at the cost effectiveness of this intervention versus standard of care, which is doing what we're already doing. And then 3, to examine the sustainability of that self-care behavior, adherence for viral suppression of youth following the intervention. But building, Tech to Check came in on top of the heels of Maria Trent's very successful intervention for PID. So Maria Trent looked at adolescent girls who were diagnosed with PID and found that they were not completing treatment and had higher rates of persistent infection, repeat infection, and sequelae. And her intervention was a community-based care model, which its goal was to increase access to care and resources and to enhance treatment completion to promote risk reduction. She showed that it was feasible and acceptable. 94% of the field interventions were completed, and you don't get better than this. They were 100 times more likely to complete treatment, and there had decreased reinfection. So I approached Maria and said, if this worked for PID, many of our kids with HIV are very similar in terms of background, marginalized population, et cetera. Let's try to do this for HIV. And luckily, Maria worked with me and we were able to get this fund. So this is our framework, essentially thinking about how Tech to Check can impact improving our youth's attitudes and their beliefs about how they can live with HIV and how they can be successful, give them more self-management skills, improve their self-management of their ART, and then reduce environmental constraints with the goal of improving viral suppression, 6 to 12 months and 18 months. Randomized study, sample size 120, youth 12 to 25 in 3 cities, Baltimore, DC, and Jacksonville, which all fall in the government and in the HIV epidemic initiative. And the goal is to try to have these youth, again, be randomized to improve their outcomes. The intervention, community-based visits, so home or selected visits. We've had visits in Popeyes, Starbucks, as well as in their homes, medication monitoring and using tech to improve that medication monitoring, lab assessments at home, clinical assessment, environmental assessment of their home, text messages, 2-way for reminders, a behavioral intervention, which is the Partners for Adherence, CDC intervention, and then assessing their behavior and the things that are impacting their outcomes, and then coordinating with the medical care team. The goal is not to take over their medical care, but to augment their medical care. Preliminary data for Tech to Check. We've enrolled, about half enrolled for the study. Demographics, as expected, given the demographics of the population, primarily African-American, somewhat higher proportion of males, again, with a higher number of men who have sex with men, and predominantly over the age of 18. High fidelity to protocol completion, high attendance to CHN visits, showing that accrual and retention is feasible and acceptable. And again, here I want to highlight the amazing team that's been on Tech to Check, our nurse, outreach worker, and our manager, which without whom the study would not be possible. I don't have my Florida folks on here too, but they have been critical in getting the study as well. It's also given us a chance to pivot and how to address research in amazing times, which in terms of COVID-19. And COVID-19 led to significant interruptions. However, we're able to continue all of our visits virtually. We're able to collect all the study data, offsite labs, and embed additional questions, which will be able to tell us the impact of COVID on risk-taking behaviors among youth. And this is us presenting at the SAM, Society of Adolescent Health and Medicine, where we're talking to other sites and other investigators about how to do studies and how to improve outcomes for youth in a systematic way in terms of research. And so another silo potentially is treatment. I told you that additional interventions are needed to address adherence to ERT in this high-risk population. I talked about VTC monotherapy and the viral non-suppression we still saw in ACE, and thinking about a lot of the protocols that are oftentimes employed to impact. Many of those are not a criticism, but just a reality. Many of them written by individuals who are not necessarily embedded in the clinical space or understanding the different pieces. And so I've looked at it as my duty to bring the pieces, the silo from clinical research together in terms of how we optimize treatment. If you have been watching the news, you do know that long-acting injectables in the form of cabotegravir and rilpivirine have shown tremendous promise in terms of treatment of HIV. And this is the New England Journal of Medicine publication that highlighted the 96-week results for cabotegravir and rilpivirine injectable given every 4 weeks versus every 8 weeks compared to given oral antiretroviral treatment with cabotegravir, rilpivirine, and abacavir. This was done in multiple studies, including the USA, Spain, France, and Germany, about 300 plus treatment-naive HIV positive individuals, 18 and above. And what you see here is the virologic response rates at 96 weeks, showing that at the 8-week regimen, similar to the 4-week regimen, were superior to oral antiretroviral treatment. Actually, this was non-inferior to oral cabotegravir in terms of viral suppression. But this slide is the slide that garnered a lot of attention. What you see here is satisfaction in the pink and how satisfied people were in terms of their current treatment. Higher satisfaction for those in the injectable version, whether it's every 4 or every 8 weeks, and in terms of whether or not they were going to continue on that modality, higher rates among those on the injectable. And this has led to approval of Cabernuva for 18 years and above with individuals at viral loads who are suppressed. Impact 2017, we are involved in that study, is looking at those 12 to less than 17 years of age, again with virologic suppression already. But I spent the first half of this talk talking to you about individuals who are non-adherent. Ethel Well, who is a clinical pharmacology / ID fellow, asked a question among youth whether or not they wanted injectable agents. And what you see here is a study she did in 3 cities in the HIV epidemic locations. So Baltimore and Nashville and Memphis, Atlanta and Memphis, sorry about that. And what she saw was that there was high interest for injectable agents, but definitely the interest increased the higher.
Hello, do you know if you sell spaghetti and marshmallows?
Individuals viral load was. Someone needs to mute. I don't want spaghetti. Also, what we saw in terms of comparing willingness to use injectable, the willingness to use injectable increased the less frequent you gave the drug. So once every week, about half. Once every 2 weeks, a little bit more. Once you got to monthly or more, the interest in injectables increased even higher. So using that, Ethel Well and I are co-protocol chairs of a protocol called Impact 2022, looking at injectables for non-adherent youth. Approved by the network, however, having some challenges in having to advocate in terms of accessing the antiretrovirals and long-acting injectable, because now it's been approved, we're concerned that there may be less interest in having this studied for non-adherent youth, but advocating around that where the protocols is approved. So youth with HIV, in terms of treatment directions, we really need to be thinking multimodal strategies and approaches for treatment and remission. So in terms of the biologics, fewer pills, smaller pill size, fewer drug interactions, better tasting, more options. But ART next generation, long-acting, different delivery modes, talked about Cabernuva, but again, for non-adherent youth, important. But then other strategies, monoclonal antibodies, activated T cells, vaccines, expanding the armamentarium, but not forgetting to include youth as part of the conversation. And then in terms of cure, latency reversing agents, et cetera. This is the report of this, the teenager in France who had been off antiretroviral therapy for years and still suppressed. And then our own Debbie Prasad from Mississippi Baby, which sparked the interest and the move and continued investigation for cure for young people, babies and beyond, and is the PI of the hopefully awarded Martin Delaney Pediatric Collaboratory, hopefully to be funded, which features youth with HIV who are oftentimes not included in the conversation. More advocacy needed to continue to push these and to include youth. So lastly, if you see something, say something. I would be remiss if I did not talk about the life course perspective that I've been given or have developed by having a foot on the peds side, a foot on the adult side, and thinking about youth that I see in my clinical spaces who are now born with HIV and now in their 30s and approaching 40s, where they're too young to be included in the adult trials or comorbidities, too old to be in the studies for children, but are sort of in this no man's land where they may be lost in the shuffle, and really have been proud to be part of different spaces where young people are advocating and talking about their unique needs and why they need to be considered as part of the conversation. So how will youth with HIV infection be impacted? We already know that there is likely some neurocognitive impacts, deficits in working memory, executive functioning and speed, defects in visual memory and spatial ability. We have significant issues with mental health, with a significant proportion of individuals with perineally acquired HIV having mental health, depression, but high rates of internalized stigma associated with depression in both perinatally and non-perinatally acquired individuals. There's issues with fertility and pregnancy and antepartum depression that we need to also be thinking about for these young people specifically. But like I said, they're being lost in the mix. This is data from the NA Accord, which is a multi-site network in the US and Canada. And you see in terms of HIV acquisition risk, MSM, people who inject drugs, heterosexual, and this other unknown or missing category includes the grab bag of perinatally acquired, where they either never acquired the information to be able to actually categorize them and then to look at them, or we just don't know. And so working with NA Accord and other networks to try to really tease out this population so we can understand what the life course looks like for individuals born with early acquired HIV. We do need longitudinal cohorts, we need modeling studies, and ultimately we need to think more critically about HIV as a risk factor for plugging your comorbidity, but then thinking about preventative strategies that may be essential for young people who are born with HIV. However, increasingly, I have told you about this part of the spectrum of the continuum where we're on our way to viral suppression. Increasingly, I've thought more about the HIV prevention. I would love to be out of a job. I would love to not diagnose another 13 or 14-year-old with HIV who didn't know that they should use condoms, or didn't have access to PrEP. I spent a lot of time thinking and working with young investigators, many pictured here, Johannes Thrill, Ethel Well, Devon Jackman, Hasia Yusuf, and Ann Nyland, thinking about strategies on the other part of the spectrum, but increasingly working with my adolescent colleagues, including Errol Fields, Maria Trent, and Renata Arrington-Sanders, about how we can increase access to prevention, talking about it, surveying it, but also access to PrEP and new strategies for PrEP for young people, and advocating again for young people to be part of the conversation. So what else is needed to optimize outcomes for youth? And I think it's really critical that they don't just survive, but we have to optimize. And this is a quote from Maya Angelou that I love, where my mission in life is not merely to survive, but to thrive, and to do so with some passion, some compassion, some humor, and some style. We need to consider youth specific. We need to include their voices early and often. We need behavioral and community interventions, that break silos. We need clinical and research. We need implementation science. We need optimal care models. We need to integrate different venues for care delivery, including leaving our clinical spaces and meeting youth where they are. We need virtual spaces, real world spaces. And then we need to predict and address complications early and often. And we need to think about personalized medicine and how we do this differently and better. In terms of the modalities and what our portfolio looks like, I think it needs to be multidisciplinary, it needs to be multimodal, it needs to be relevant and specific to youth, and has got to include the youth voices. Real world clinical research partnership, they cannot be in silos, they have to go hand in hand. They need to be creative and innovative, they need to think about the ethics and regulatory issues, but we also need to not stop there, and we need to advocate and need to push the guidelines to make sure that youth are included and thought about. This is what the picture looks like, and I'm really proud to be part of a network of investigators here at Hopkins and beyond that are really looking at this continuum from the prevention all the way to viral suppression to cure. So when I go back to that framework that was in my K23 application and how simple it was looking back, and provider and the treatment and eligible youth, et cetera, and really acknowledging that it looks more like this. It's all of it and more. Thinking beyond engagement, retention, loss of follow-up, treatment strategies, approaches, but changing paradigms, bringing the clinical, addressing different social terms, et cetera, in order for us to get to that treatment success in a meaningful way. So at the end of the day, it is putting the care, the research, advocacy, and the treatment all together. It is not just bridging the silos, but it's busting them down and making sure we all are in one big silo, one big sandbox. In conclusion, youth with perennially acquired HIV are surviving into adulthood, and new infections continue among adolescents. There's significant medical and psychosocial challenges that exist that can lead to poor outcomes, and we need to specifically consider youth in coordinated research, clinical care, advocacy to achieve the best practices and the best outcomes. But it can be. So with that, I'd like to stop and really I've tried to highlight them along the way so the slide wouldn't be endless, but I really want to highlight my entire global team, my network of providers, my network of mentees, really the large, bigger picture, all pushing to improve outcomes for you. I started with the funding. You can't do any of this without the funding. But I started with an African proverb, and I want to go to end with an African proverb. And instead, if you want to go fast, you go alone. But if you want to go far, you go together. And my goal is to go far in terms of optimizing outcomes for youth. And it really has been my privilege and pleasure to do it here at Hopkins with people that I really care about and are passionate about this population with me. With that, I will stop sharing my screen and be open to questions. Thank you very much.
Thank you so much. That was such a wonderful presentation, and thank you for taking us along on your journey and describing, the different studies that you've done. That was really, truly fantastic. The chat is open. If anybody has any questions for Dr. Agwu, there are many comments already saying what a wonderful presentation this was, and that this is really a wonderful body of work.
Thank you very much. Thank you. It's really wonderful to see my mentors on the call and to see many of the trainees that really make it all matter, yeah, I'm humbled. Thank you for your attention and really open to any questions that you may have.
Wonderful.